which involves semaglutide. This is the injectable semaglutide in Sustain 6 and the oral semaglutide in Pioneer 6, showing 35 to 26% risk reduction. So maybe semaglutide may be a preferred GLP-1 if the goal, again, is to prevent recurrent stroke. This is the PROACTIVE study, an older trial using pioglitazone. Again, the MACE effect was on the same order of about 16%, but you remember that that was a secondary outcome in PROACTIVE. The primary outcome, which include peripheral vascular disease events, rendered the primary non-significant, and the effect on MACE was also counterbalanced by this 41% increase in heart failure hospitalizations. This is the PROACTIVE breakdown involving the myocardial infarction outcome as well as the stroke outcome. And here, interestingly, you start to see more significant benefits for MI in those patients with prior MI. There's a 28% relative risk reduction. And for stroke in those patients with prior stroke, nearly 1,000 patients, the risk reduction was a very impressive 47%. This suggested that there may be a unique benefit in terms of stroke prevention. The IRIS study is the insulin resistance intervention after stroke trial, randomized patients with TIA or stroke who did not have diabetes but did have insulin resistance based on the HOMA equation, randomizing them to pioglitazone or placebo. Many of these patients ended up having pre-diabetes because we excluded patients with diabetes and we attracted a patient population that had insulin resistance. And here's our primary outcome, which was 24% relative risk reduction in favor of pioglitazone. And when we break down the individual components of the primary, so this is stroke alone, using the updated definition, relative risk reduction was 25%. All of the effect is on ischemic, not hemorrhagic stroke. And for acute coronary syndrome, which is another complication in patients with stroke, with a prior history of stroke, that the relative risk reduction was 25% as well. And interestingly, most of the effect was in type 1 MIs with a 38% risk reduction. Heart failure was, as mentioned, a concern in PROACTIVE. In IRIS, we actually excluded patients with heart failure, and the drug was allowed to be dose reduced in those patients that developed edema. So this was more of a real-world aspect to IRIS, that some dose adjustment was allowed during the course of the trial. And you can see that any heart failure